Good morning, everyone. And actually, we were supposed to start the transplant related talks from today, but there was some uh, continuation from the previous ones. So today I'll be speaking about acute cellular rejection, late acute rejection, and chronic rejection, and antibody mediated rejection, that is B cell mediated rejection, will be taken by Dr. Rajiv subsequently. So my first disclaimer is I am not an expert and I have not been working on in this field, and understanding rejection requires a clinician's perspective, which I may be able to provide. Some basic science which I have read, but immunological perspective and histological perspective, I am quite sure people sitting in the audience may have a slightly better understanding, definitely a better understanding than me. Now, when I say acute cellular rejection, we mean T cell mediated rejection, and B cell mediated rejection is antibody mediated rejection. So acute cellular rejection is mainly the inflammation of the allograft. Why? Because of the genetic disparity between the donor and recipient, and primarily affects the interlobular bile ducts and the portal and the hepatic veins, and the same is used for histopathological diagnosis of acute cellular rejection. Now, contrary to the term, there is no time period to say that it is a case of acute cellular rejection. However, most of them occur within a month, and most of a significant proportion occur within the first 1 year. What is different is the acute cellular rejection which are happening within the first 1 month are usually milder and are easily controlled by immunosuppression, whereas the episodes which are occurring late in the course are difficult to control and are known to cause graft damage even if it is the first episode of acute rejection. Now this, I think most of you very well know that activation of the recipient T cells in response to the donor antigen presenting cell is the direct pathway. Now, when the antigen is presented by recipient antigen presenting cells which have taken up the necrotic and apoptotic cell materials from the allogenic donor cell, it is the indirect pathway. And then there is this semi-direct pathway where the recipient T cell is presenting the acquired donor HLA peptide complexes. So these are the three ways by which antigen can be presented to the recipient CD4 T cells and which get activated. Now this is again a very basic one, mainly for the residents, that recognition of the non-self antigens on the antigen presenting cell, mainly from the MHC2 complex, on the T cell receptor of the host cell leads to the T cell activation. Now this is known as signal 1. What also happens simultaneously is the antigen recognition accompanied by interaction of CD80 and CD86 on the antigen presenting cell with the CD28, that is the co-stimulatory receptor on the T cell, and this interaction is known as signal 2. Signals 1 and signals 2 activate the signal transduction pathways which include the calcium-calcineurin pathway, RAS mitogen activated cytokines, and the nuclear factor kappa beta pathway, and this ultimately leads to this cytokine activation and leads to release of interleukin 2. Now this interleukin 2 has a kind of paracrine properties, and it leads to activation of more and more T cells. And the third signal is this interleukin 2 interacting with the interleukin 2 receptor on the other T cells, leading to proliferation of the T cells, and ultimately further proliferation of T cells leading to rejection. So these are the three signals which are required for activation of T cells. Now upon activation of the cognate antigens and co-stimulatory signals, now this naive CD4 plus T cells can acquire graft destructive properties or graft protective properties depending on the local cytokine microenvironment in which the T cell activation occurs. In presence of pro-inflammatory cytokines like IL-12 or IL-4, this naive CD4 T cell can differentiate into Th1 or Th2. In presence of TGF-beta, it differentiates into Treg, and in presence of TGF-beta but with also presence of IL-6, IL-21, it differentiates into Th17. So Treg, we all know, if there is Treg, then it usually goes towards tolerance, and Th1 and Th2 goes towards inflammation and rejection. Incidence of rejection, I will not go too much into this. 15 to 25% in this TAC based immunosuppression, and before pre-TAC era it was quite high. Similar results are seen in the pediatric liver transplantation. We can see that in the previous era it was close to 60%, and latest it is around 40% will have at least one episode of acute cellular rejection. Again, the same thing, that by this they have used the Banff criteria and seen the timing and the severity of rejection, and this show that 72% of the acute cellular rejection are occurring within the first year, most of them occurring within the first 30 days, and moderate to severe rejection are less common during this period, and usually the response is good. Late acute cellular rejection occurring usually beyond 1 year, the higher chances of them being moderate to severe, and these are usually seen in patients who are either non-compliant, or we are not able to give adequate immunosuppression due to either sepsis or some serious infection, or due to risk of PTLD. However, not everything is rosy here, and some acute cellular rejection can lead to very severe forms and graft loss, shown in a recent study by Levitsky et al. In 2017, where they showed that in patients who are having a biopsy-proven acute rejection, the risk of graft failure and graft-related mortality are high. The risk of graft failure is higher in those who have received an unrelated liver, and also this line, that those who have got the first rejection beyond 12 months after transplant, they have high risk of mortality and graft failure within 12 months from that rejection which has happened. So not all acute cellular rejection are milder, and hence we need to diagnose them in time and treat them accordingly. Risk factors, yes, recipient's age, higher age, lower age are risk factors, but infants are relatively safe, and you can see here that the infants are at the lowest risk, obviously because of the their immune phenotype, they are at the lowest risk. Then the primary diagnosis, anything that is related to autoimmune process will have higher risk of rejection. Poor compliance, higher risk. Cyclosporin we already know. Among the donor factors, donor recipient mismatch, unrelated donors, and donor age, and among others, infection like CMV, surgical factors, higher cold ischemia time can lead to increased risk factors of ACR. Diagnosis of ACR, we are all very well aware that there is a global assessment part, and then there is a rejection activity index, which includes the three part: portal inflammation, bile duct inflammation, and venous endothelial inflammation. That is standard across since 99, and then this was modified in 2016, but the rejection activity index or cellular rejection part has not been modified in this in 2016. Only antibody mediated rejection was defined there. One thing is this, that those rejection which present with high GGT usually have more of bile duct inflammation as compared to portal inflammation and venous endothelial inflammation. This case received LDLT in 2017 for indeterminate ALF, had a normal graft function for 2 years. Now you can see that the first acute rejection is coming quite late. 2 episodes of acute rejection in September and November back to back, both time treated with methylprednisolone, responded, but then he developed some adverse effects related to tacrolimus, which was proven by bone marrow. It was stopped, and after stopping he developed another episode of rejection in April 2020. However, despite these 3 rejections, he continues to do well and has not gone into chronic rejection. You can see the typical biopsy findings. There is portal inflammation, the bile ducts are showing inflammation, and then you can see the portal vein endotheliitis and central vein endotheliitis and lymphocytic inflammation around the central vein. Now this was the first biopsy. This is a biopsy done 4 weeks later, which shows that all features of rejection have disappeared, and this is the third rejection which happened after stopping TAC again. Now there are several limitations with biopsy. Yes, it is gold standard, but it is invasive. It is comparatively difficult. I think all of us get it done through the ultrasound guided from the IR lab. There are obviously risk of complications, and if we delay the biopsy and first give immunosuppression, it can change some findings, like subendothelial infiltration of veins can resolve within 24 hours, and we may be confused that whether it was actually rejection or not, but most findings usually take 7 to 10 days to resolve. And third thing, biopsy is usually done late, so it cannot predict ACR, except for this surveillance biopsies which are done. So can we do non-invasive diagnosis of rejection, and what is the role of biomarkers? Now several biomarkers have come up, and this is the area where I could find the maximum work is going on in the field of rejection after liver transplant. Now biomarkers are basically it's mainly the omics based biomarkers which are being studied recently, and things which you can detect in the serum of the patients. So biomarkers have been used for diagnosis, prediction and prognostication of acute cellular rejection, and nothing is still standard of care, but a lot of research is going on. So why will be the biomarkers released into the serum? Whenever there is a immune mediated injury, the markers of this immune activation can be detected in the serum, one, and second, when these immune cells cause cell death in the graft or apoptosis, cell death in the graft, so after the death the hepatocytes will release some markers, and these can be then detected in the serum. So it could be omics based diagnosis biomarkers could be DNA, where it could be the single nucleotide polymorphism, but this is very difficult because there will be so many single nucleotide polymorphism, and most of them are not known to alter the gene function. So what is most recently being studied is cell-free DNA, which we will see the studies now, donor-derived cell-free DNA, RNA, among that microRNA and messenger RNA, proteomics and metabolomics. So I'll spend a minute here on the donor-derived cell-free DNA. So almost all the cells in the body release some DNA into the plasma. So, and mostly it comes from the apoptosis of most of the cell-free DNA. Cell-free DNA means the DNA which is not inside a cell, it is just in the plasma. So most of these come from the apoptosis of the blood cells in the circulation. So if you take a sample from a patient, most of the cell-free DNA will be coming from the recipient's red blood cells or other cells and organs. But if there is a liver injury happening, graft injury happening, then due to this injury, there will be release of cell-free DNA which will be coming from the donor. So it is called donor-derived cell-free DNA, and this can be detected in the circulation. Now, we can, by genotyping, mainly it's done through the NGS way, but the other method is by short tandem repeats, that is by microarray technique. So by these two techniques, we can differentiate which part is from the donor derived and which part is from the recipient derived. And they use a calculation, that is donor derived cell-free DNA as a proportion of total cell-free DNA. And obviously if there is more of graft injury, there will be more of donor derived cell-free DNA. So a higher percentage of cell-free DNA is indicative of graft damage, especially immune mediated damage, depending on what kind of cell-free DNA we are seeing. Not only the quantity, the quality of cell-free DNA is also important, and it has been shown that the smaller DNAs, 100 to 250 base pairs cell-free DNA, are usually released from the after graft-mediated injury, and larger base pair DNA cell-free DNA are usually released from the recipient. So let's see the study published in American Journal of Transplant just a couple of months back, I think, for diagnosis as well as prediction of T-cell mediated rejection. And here you can see that the proportion of donor-derived cell-free DNA is very low in transplant patients who are normal, is higher in transplant patients who have graft dysfunction but not rejection, and highest in patients who have graft dysfunction due to rejection. And the cutoff that has been come from this study is 5% to differentiate between acute rejection versus normal transplant, and more than 20% differentiates acute rejection from other causes of graft dysfunction, although sensitivity takes a hit when we are comparing acute rejection with other causes of graft dysfunction. Sorry, specificity takes a hit. Now what is most important here, if you follow this slide, that this is the cutoff of 5%, this is a cutoff of 20%. Now this blue line is normal transplant patients who have not developed any graft dysfunction. You can say that the percentage donor derived cell-free DNA is constant. This is the time point where liver biopsy was done after elevation of after clinical detection of liver injury. Now you can see that minus 75 days, the percentage of donor derived cell-free DNA has started rising in cases who went on to develop acute rejection. And at minus 50 days from the acute rejection, it has crossed the threshold of 20%. So what this tells us that 50 days before the biopsy proven rejection, we could have diagnosed acute rejection if the cell-free DNA was being used. And even if you use the whole 95% CI, we can see that the 95% CI is about 20% as early as minus 30 days from the day of biopsy. And the second thing is that once it goes up, and as soon as you treat the rejection, it comes down. So it is a dynamic parameter. Again, this shows the same thing, that you can see here the ALT. The ALT is rising very slowly. It has not risen till here. It will rise only after this part, when actual clinical detection happens. But the cell-free DNA is rising much prior to that. So there is a definite result to show that at least minus 30 days from rise of ALT, this rise of cell-free DNA happens and can be detected in the serum. Now the other part is, can you the cell-free DNA, whether it is coming only from whether it is actually coming from the liver or not. Now for that there is some role of tissue specific or hepatocyte specific cell-free DNA. And now in this study they characterized 3 genomic loci that are unmethylated, specifically in hepatocytes, whereas these loci are highly methylated in other tissues, and to allow the identification of hepatocyte specific DNA. Now elevation of hepatocyte specific DNA was seen immediately after transplantation. We can see this 1 is pre-transplant, 2 is post-transplant. So post-perfusion there will be a rise, but then 9 days after transplant you can see that the hepatocyte specific DNA has gone down. Now it will further rise only in case of rejection or graft dysfunction happening after that. That same thing can be seen in the graph here, that yes, so that limits its use. Now cell-free DNA use is limited because in the first 10 days it will be high because of the ischemia reperfusion injury that is happening, and thus interpreting this in the first 10 days or at some studies first 30 days may not be possible, but yes, beyond that it is definitely very useful. What was the advantage with these people was they were doing this study as part of immunosuppression withdrawal studies. So they had serial samples available with them, and as immunosuppression was being withdrawn, they were taking serial samples, and thus they had this advantage of doing this NGS on several time points prior to actual rejection happening with decreasing immunosuppression. Coming to the qualitative part, that yes, cell-free smaller, that is 100 to 250 base pairs cell-free DNA will be higher in rejection as compared to non-rejection, and bigger ones will not be clinically will be different between the two groups. However, this was not very significant, and this is only one study which is again published in liver transplantation just a couple of months back, but we need further studies on the qualitative aspect and the size aspect. But then there is again another study in transplantation, again 2022 study from Levitsky again, and they showed that a 59 gene signature panel can be used to predict the development of acute rejection even before it has happened. Now coming to the next part after the cell-free DNA is an excellent one. The second excellent biomarker for diagnosis of acute rejection is circulating microRNA. I will again take a minute here, that circulating microRNA can be released from living cells, like here from in the form of exocytosis, and it stays in the blood vessel, in the plasma, in the form of microvesicles, in form of exosomes, or inside the HDL particles. Or the microRNA can be released from the cells, passive release after cell death, and they are usually in the form of apoptotic bodies or ergonaut bound. Most of the microRNAs are in the form of ergonaut bound. So now these microRNAs which are there in the blood vessels, in the plasma, can be detected by several techniques and can be used for as a surrogate markers. So let's see the studies. This was one of the earliest studies, Hepatology 2017, where they done the microRNA profiling in 318 samples from 69 liver transplant recipients. Again, the group was same, the patient group was same, this immunosuppression withdrawal studies, and these two trials. One they used as testing cohort, and other as the second cohort, validation cohort. So they found that 31 microRNAs were significantly different in acute cellular rejection compared to non-acute cellular rejection, and compared to normal transplant patient, and 2 microRNAs were significantly different between ACR and non-ACR. These were microRNA 483.3 and microRNA 885P, and they formed a signature that is a model based on these two, and tested it on training set and test set, and found that it has a very high AUROC of close to 90% for differentiating acute rejection from other causes of non-rejection graft dysfunction. So this you can see that the area under curve is very good, and again this microRNA signature was also elevated at minus 50 days. You can see the red one is acute cellular rejection and blue one is non-acute cellular rejection, and you can see that this signature of these combination of these two microRNA has started rising, and the 95% CI is completely beyond this 95% CI at minus maybe around minus 40 days before acute rejection has actually happened. So this tells us two things. One, the graft injury possibly starts around say 6 or 7 weeks before it becomes clinically apparent. So this we can understand from this study. And the second part is we definitely have a good window of around maybe 30 days before we are actually doing the biopsy and treating the patient, and treating them at this time point may actually prevent the risk of permanent graft loss or graft damage that happens. An older study which showed some other microRNAs which are either overexpressed or underexpressed, won't go into that. There are several microRNAs which have been studied in serum samples. These are the ones which I showed recently, 483 and 885, but there are some which have been detected in the tissues, also. So after the DNA, RNA, we come to the proteomics, that is the proteoforms. Now, in this study, differentially processed and cryopreserved cell lysates from 26 post-transplant patients, 8 with good outcome, 9 with rejection and 9 with non-rejection dysfunction, were analyzed by LC-MS, and we can see that that actin sequestering proteins like thymosin B4 and thymosin B10, these were abundant in the acute rejection group, and these proteins thymosin B4 and thymosin B10 are actually involved to attenuate platelet function and activate hepatic stellate cells. Metabolomics have been studied in some studies, but I couldn't find the more recent ones on metabolomics. They have used serum bile acids, taurine conjugated bile acids, phosphomonoesters, phosphodieesters, the substrates of the COX pathway, substrates of the nitric oxide synthetase pathway, etc. We'll skip this. Peripheral eosinophilia has been shown by 4 studies, interleukin 2 receptor by 1 study. Okay. Then, as I said that among the DNA, single nucleotide polymorphism has been shown by several studies, but then these have not given very strong results, and yes, they can only be done after that rejection has happened. So among them, IL-13C polymorphism has been shown, IL-4 polymorphism has been shown, and difference in the recipient and donor GSTT1, that is glutathione S transferase 1 genotype, has been shown to predict the development of rejection. Diagnose in the rejection. Elevated levels of circulating mitochondrial DNA has been also been studied in one study recently published in 2021. Now, is there a potential role of EVs? Yes. Recent studies have demonstrated that EVs, we know, facilitate intercellular and interorgan communication, and it has been suggested that through the internalization of EVs, bioactive components such as microRNAs, mRNAs, proteins which are present in them, they can alter the gene expression and the physiological response in target cells. So by targeting these EVs, we can detect a lot of signature of what is happening in the graft, and in case of graft injury, whether these are different. So these can be studied subsequently. So after the biomarkers, which are the DNS, mainly the cell-free DNA, microRNA, mRNA, proteomics and metabolomics, there are a few studies which show that transient elastography to differentiate acute rejection from others doesn't make much sense, but yes, it has negative predictive value that a T less than 4.4, 4.4 or maybe 5.3, I'm not very sure, maybe 4.4 definitely rules out a rejection. Whenever rejection is happening, there will be increase in stiffness of elastography, but this has not been consistent over studies. Differential diagnosis for TCMR, we all are very well aware: vascular causes, biliary causes, preservation injury, AMR, infections, biliary causes. Skip this. So
summarize now, and any data from ILBS.
Yes, sir.
I know you got less time than you're due, but we need to.
Just one point on surveillance biopsies, that although there are previous reports that surveillance biopsies do not help, there is a recent study on pediatric liver transplantation 2022 that shows that patients who received surveillance biopsies, at least 15% of them rejection was found despite AST-LT not suggesting them, and treating them helped in improving the rejection-free survival. And I'll directly come to the data. ILBS data, I couldn't have the most recent data, but what I had from previous, there are 102 pediatric liver transplant, and acute rejection was present in 54 of them. 54% of them had received treatment for acute cellular rejection, but biopsy proven acute cellular rejection was only in 48. This is at least one episode. Several had more than one episode. Steroid resistant rejection was in 4. All 4 received basiliximab, and only 1 showed a good response to basiliximab, and 3 had to be treated with ATG in our group. Late rejection was 8, chronic rejection was 2, none required retransplant, but 1 death due to graft failure. This was a child with PFIC1 who developed graft failure and died. And yes, and 1 child is off immunosuppression and has developed tolerance. And this is the biopsy of that child, who is now 7 years post liver transplant, and she's 5 years. No, she's 7 years after stopping immunosuppression. Now she's 10 years from the liver transplant done at our center. Yes, and this is her immunophenotype that we did recently. So way forward, we need more Indian data on incidence and outcome of ACR and all form of rejection in pediatric as well as adult liver transplantation. We need to study the graft fibrosis on long-term follow-up. I didn't show the data, but there is data that the graft undergoes fibrosis at around 18 to 20 years after transplant, especially in the pediatric transplant. We need to do the biomarker studies because we have a lot of clinical samples, so we should, and we have the basic science expertise, so we should do this. And response of steroid resistant rejection to ATG, because we are using ATG a lot in recently. So protocol is obviously from the literature, not much of my role in this, but yes, in liver transplant recipient, we have to decide whether we need to do a protocol biopsy in pediatric LT recipient. This has to be again based on evidence, but evidence suggests that protocol biopsy has role, at least in pediatric liver transplant rejection. When you are suspecting acute rejection, obviously apart from ruling out all other causes, I think we should keep samples for biomarkers, so that as a part of study, I think that can be done. And graft biopsy, if it is acute cellular rejection, we treat with methylprednisolone 10 mg per kg for 3 days and followed by tapering. And it has been shown in studies that this protocol, 10 mg per kg and then tapering, is better than giving it suddenly stopping it and shifting to prednisolone. So after 7, usually we taper and then shift to prednisolone 2 mg per kg and then taper further. And steroid resistant rejection, we have failed with basiliximab, so maybe we can consider directly going to ATG rather than going through basiliximab.